Great. Well, welcome everybody. I'm Eric Potashnik, a professor at the Watson Institute and the director of the MPA program. I also want to let everyone know that this event is being recorded and webcast. So please be aware of that if you ask a question, which we look forward to your participation later. Addiction to opioids, including prescription pain relievers and illicit drugs such as heroin and fentanyl, impose massive costs on both individuals and society. On average, 130 people die each day due to an opioid overdose in the US. And between 1999 and 2017, the opioid epidemic claimed nearly 400,000 American lives. More Americans die from fatal opioid overdose than from gun homicide or car crashes today. Here in Rhode Island, the opioid epidemic is a major public health crisis. From 2011 to 2017, opioid deaths in Rhode Island increased by almost 90%. Rhode Island's opioid overdose death rate in 2017, which was 27 per 100,000 individuals, was the 11th highest among the 50 states. So there's been a lot of progress in Rhode Island in recent years, but it's still a major problem here. Preliminary data for 2018 indicate that national overdose death rate has leveled off, yet overdose deaths still remain at record or near record rate. The increase in deaths from opioids and other drugs has been so steep, in fact, that they have contributed to a reduction in US life expectancy over the last 3 years, something that hasn't happened since World War II. Policymakers have tried many different approaches to reduce opioid abuse and opioid-related mortality, including medication-assisted treatment, prescription monitoring, education, treatment for prisoners, and harm reduction strategies such as syringe exchange. And these approaches raise important questions for both practice and research. What have researchers learned so far? What strategies are most promising? How can we deal with the dual problems of stock and flow, helping the current stock of people addicted to opioids, limiting the harms associated with drug use, and providing appropriate pain treatment to patients who need it, while also lessening the flow of new generations of people from misusing opioids in the first place? And yet more questions. How strong is the scientific evidence for different strategies? And how much confidence should we have that we are pursuing the best mix of policies today? If there is scientific uncertainty about the costs and benefits and trade-offs of particular policies, what kinds of research studies and data infrastructure do we need to gain knowledge and promote beneficial, cost-effective, evidence-based solutions? And finally, how can scholars from different disciplines, including public health and economics, contribute to research on the opioid crisis so that each discipline brings its distinctive strengths to the table and helps bolster the weaknesses of other communities? So this plenary session, which I've been very excited about for a long time, brings together two leading scholars to discuss the history of the opioid epidemic, the state of the evidence base, current implementation strategies in public health, and promising directions for both research and practice. So it's my pleasure to introduce them now. Jennifer Doliak is an associate professor of economics at Texas A&M, a non-resident fellow in economic studies at Brookings, and the founder and director of Justice Tech Lab. She's an applied microeconomist who's published in leading journals, including Journal of Labor Economics and Review of Economic Statistics. Much of her research focuses on the economics of crime and discrimination. She's an expert on how technology and surveillance affect public safety, with research related to DNA databases, gun violence, campus sexual assault, juvenile curfews, and other topics. In recent work, she considers how ban-the-box policies affect employment discrimination against ex and non-offenders. She recently published a Brookings Institution paper on what the evidence says about how to fight the opioid epidemic. She's spoken at the White House, advised the ACLU, testified before Congress, and had her research in DNA databases cited by the Supreme Court. She is an NBR NSF Crime Research Fellow and previously taught at the University of Virginia, where I had the pleasure to be her colleague, and worked at Brookings and the Congressional Budget Office. She holds a PhD in economics from Stanford and a BA in mathematics and economics from Williams College. Harold Pollack is the Helen Ross Professor at the School of Social Service Administration and co-director of the University of Chicago Crime Lab. He's published widely at the interface between poverty policy and public health. His research appears in such journals as Addiction, Journal of American Medical Association, American Journal of Public Health, Health Services Research, and Pediatrics. His writings have appeared in many popular outlets, including the Washington Post, The Nation, the New York Times, and other publications. His American Prospect essay, Lessons from an Emergency Room Nightmare, was selected for the collection Best American Medical Writing in 2009. Professor Pollack has been appointed to 3 committees of the National Academy of Sciences, received his undergraduate degree in electrical engineering and computer science from Princeton, and he holds a master's and doctorate in public policy from the Kennedy School at Harvard. So I've asked each of them to speak for about 25 minutes, and then we'll have a chance for the 2 of them to have some dialogue, and there'll be plenty of time for questions from the audience. Since Harold's remarks will involve some background material and his history, I asked him to go first to set the scene. So thank you, Harold.
I have PowerPoint. I need logical track. It's been so long since I've used a PC that we'll see if I'm able to master the technology, despite my electrical engineering background. They're apparently not. So, so I want to do a couple of things today. Let me just set up the slideshow here. Slideshow, there we go. So in the 3 hours that I have for my presentation, I thought that I would cover a couple of different things. One is I want to go down memory lane and talk about my own experiences in harm reduction as a postdoc, and talk about syringe exchange as kind of the paradigmatic example of what we hope harm reduction will do, but also one that in some ways is a little too easy and gets us out of some of the dilemmas that we need to think about for the opioid epidemic. And so that we can talk about the necessity, but also the limitations of harm reduction in what we can accomplish. And then talk about some policy recommendations and how different communities can talk. So I should say I did my doctorate at the Kennedy School, and while I was at the Kennedy School, I had a girlfriend who was living in New Haven, and wrote a dissertation that I made into a doorstop, and a health policy postdoc opened up in New Haven, which I decided health policy is a really important thing. So I went down to New Haven, and I got involved in the city in something called the Community Healthcare Van. This is what it is. It's a mobile clinic that was parked behind the city's syringe exchange at the time. And that kind of changed my career. I had spent my time doing my dissertation in the basement of the Harvard Science Building. That was the day when you put on the data tapes and spun them, and then waited a long time to discover that you had one error in a line of code, and then sort of rewound the tape and try it again. And the people that I met in the New Haven Needle Exchange, these are some of my colleagues here. Maybe some of them are watching the live stream. Rick Altice, Kaveh Kashnud, Ed Kaplan, and Colleen actually was at Yale at the time when I was at Yale as well. It was just a transformative experience for me. So one day I would go and volunteer on the CHCV, and I would just talk to people. And it was kind of an amazing thing. One day I went on, and there was a gentleman there who was younger than I am now, who looked maybe 65. He was just totally weathered. And he came and I said, can I help you? I was helping people fill out the intake forms for their healthcare exams. There was a wonderful nurse practitioner named Mary Pat Lamperti who was taking care of people. And he pulled his shirt aside, and he had a crater in his shoulder that was maybe the size of a $50 and maybe a third of an inch kind of deep. And I looked at it and I just broke. And it was just an abscess as an injury from a needle stick that he had. And then a younger man came on who was maybe 21, who was very, very nervous. He wanted an HIV test. And this is the days just before heart medication. And so somebody tested HIV positive. Pretty good idea they were going to be dead at some point, not distant future. And the people came out. He got in his underwear, and he just lay on the floor, and they couldn't find a vein where they could cleanly get some blood because he had everything he had so injected that eventually they brought out a special butterfly syringe and they were able to do the HIV test. And I looked at these two men, and one looked like the time release, one looked like the aged version of the other. And then this young woman came on who was a sex worker, and she was very grimy, she was homeless, and I was actually kind of scared to be next to her because she didn't smell very good, and she was kind of sniffling, and I was kind of scared to be in the physical presence of this person. And Rick Altice, who's the physician there, comes out and he sits down next to her. They're both sitting cheek by jowl on the little stools in this little van, and he pulls out an apple and a pocket knife, and he says, "Would you share this apple with me?" And he cuts the apple, and he and this woman share this apple while he does this amazing clinical interview and talks to her about all of the issues that she has with her health and why she was there that day and the kinds of STIs that she might have and so on. And the amazing and it was just amazing to watch Rick do this unbelievably skilled clinical interview in such a completely seamless way. And none of those three people would have ever engaged for any kind of help if this was not parked right behind that syringe exchange where they could get that clean, sharp needle that they wanted for their because they were the people who injected drugs. And earlier today we heard Brandon Marshall talking about the supervised injection sites in Vancouver. And when harm reduction is done well, it's a way to create a relationship and to engage people in treatment and to really deal with the problems that they have. And one of the real tests for a harm reduction intervention is, are you actually doing that? A lot of syringe exchanges around the United States don't look like what I just described. What they look like is a place where you can kind of go and somebody hands you a set of syringes and you're on your way. And I'm sure they're way less effective for helping people. So syringe exchange as HIV prevention is an incredible lifesaver. And it would have saved many more lives if policymakers had embraced it the way that, say, Margaret Thatcher did in Great Britain. Many cities of Western Europe had populations of people who inject drugs, very, very low HIV prevalence. If you go to Amsterdam, many of the cities in France, Northern Europe, they effectively controlled HIV. And we had a different experience in the United States. And one reason we had a different experience was from people like this, that our students remember as the official bad guys of social policy of the early 1980s. Who's that guy over there on the left? That's Jesse Helms. One of my favorite ACT UP things was that ACT UP went to Jesse Helms' house and they put a giant condom over his house. And they basically called it safe policymaking. And it really, we need to, when I show my students just consented debate from that day, they can't believe it. They honestly cannot believe it. They actually can believe it about Jesse Helms, but they can't believe it when they listen to the liberal and moderate senators, what they were saying about drug use and sexual minority. But there was also, in the case of syringe exchange, there was another set of opponents too, which my students are a little more surprised by, which are these people. The most prominent opponents of needle exchange in the United States, other than Jesse Helms, was the Congressional Black Caucus. And Charles Rangel and David Dinkins and Benjamin Ward, who was the police commissioner in New York City. And what they were very upset about, they were upset about a couple things. One is they were upset about the fact that no one was doing anything about the big social problems in a lot of the communities that had very high HIV prevalence. And when there's powerful social neglect, and then you show up and say, well, we're not going to help you with jobs or drug treatment or criminal justice, but by the way, here's a nice, clean, sharp, sterile needle so that this guy who may mug your aunt can avoid getting an infectious disease. People are not going to be super enthusiastic about that, and they weren't. And they also worried that it was sending an ambiguous message about drug use. And so, Mayor Dinkins said that the syringe exchange would send the wrong message, making injections safer when we should be trying to stop drug use completely. And for many people, in the harm reduction community, this experience is still with us in a very powerful way. Now, syringe exchange as HIV prevention is a very useful model, but it's also worth noting that it's really the best case for harm reduction you could possibly imagine. You have this thing where you say, please do exactly what you're doing, but just use this clean, sharp needle. Give us your old ones back, and here's your nice new clean, sharp needle. Use that one. And we have this thing that's very inefficiently transmitted that we can really, really slow down through the use of sterile syringes. And the amount of behavior change that was demanded was very minimal. It's very, very different from, for example, naloxone, where you have a lot of moving parts in what we want to happen. And you know, harm reduction is always the right question, but it's not always, we don't always have a good intervention. I like to tell my students about failed examples of harm reduction. I think the most prominent one is the filter cigarette. Why did the filter cigarette fail as harm reduction? Anybody have a sense of that? Yeah. Yeah, it was a tempting alternative to quitting, and it didn't actually reduce risk that much. And it caused tremendous harm. And it turns out that if you look at needle exchange, needle exchange failed to reduce hepatitis C. And one of my first papers, one of my first papers that did not get a very friendly reaction was when I did some epidemiological modeling and said, you know, we're just not going to reduce hepatitis C. And in fact, when I mentioned the cities of Europe that had very, very low HIV prevalence, many of those cities had hepatitis C prevalence that was 60, 70% among street inject and drug users. And earlier today, Sarah Gullis wanted to see some equations. I can't give her some equations, but I could give, I made a little SHINee app. And I actually think maybe I'm running behind. I'll wait to see if there's questions and answers. But it turns out if you do exactly the same model, for HIV, if there's just a needle stick, there's about a 0.3% probability of infectious disease transmission from a needle stick. Hepatitis C, it's about 5 or 10 times that. And it turns out if you run it out, that needle exchange basically reduces the risk by about 1/3 of people's infectious needle sharing. It turns out for HIV, that's enough to really suppress the prevalence of HIV over time. But for hepatitis C, it has almost no impact. And that's pretty much what people saw. The same was true in methadone, by the way. Getting people into methadone treatment had very little impact on hepatitis for some of the same reasons. So now let's talk about the opioid epidemic. It's unbelievably bad, and it's also unbelievably complicated. What we have is a series of really intricate time series that are going on with really escalating levels of death, and now, of course, the synthetic opioids accounting for much of it. Now, I should point out that overdose was always a serious problem. In all the studies that anybody ever did with street cohorts of drug users, pretty much 1 or 2% of the people would die every year in the studies from overdose. It was often overshadowed by other things, but overdose is not a new problem. And of course, there's been a number of studies looking at people leaving jail and prison and the number who die quickly upon release, often from overdose. Strang and colleagues did a famous study where they recruited 137 consecutive patients going into detox and inpatient treatment. And the most striking thing was that within 4 months, they had several people die. Everybody who died was in the group of people that they identified as either partially or totally successful in their treatment. Nobody died who failed in the treatment. Treatment itself, detox itself, is a risk factor for fatal overdose because people reduce their tolerance and they also relapse, and they often relapse in a furtive way. So like I don't want anybody to know that I'm back to my drug use, so I'm hiding in my room shooting up, and if I overdose, I die. So harm reduction is the essential but imperfect reaction to this, and we know with Suboxone and buprenorphine we can do a lot. And we know with naloxone we can do a lot, but we also can oversell what we can do with naloxone. And I think it's a beneficial but reasonably weak intervention. And we lack direct data on what naloxone is actually doing. And one of the things, we have crummy infrastructure for all of these, for what's crummy data infrastructure for what's actually happening on the ground. And that puts us all in a very difficult position as we try to do policy evaluation. We really don't understand a lot of things about this epidemic. And so we don't have what you might think of as a sentinel epidemiological surveillance system. There's something called ATOM, which could have been the foundation of something very good, where in the ATOM system, people that were coming into jails, arrestees were being systematically drug tested with urine-verified drug tests. And we have not pursued that systematically to really know what's happening in a population, and particularly what's happening where our data collection process is not somehow related to our freak out over the opioid epidemic itself. Because what's happening now is we're collecting a ton of data about various things because we're like, oh my God, we have a huge problem. Let's start collecting data. Let's test all our arrestees. Let's do a lot of arrests for anybody found with fentanyl. And let's also keep track of all of our overdoses. And then we look and we say, wow, there's a huge increase in the number of fentanyl arrests, people found with fentanyl, and fentanyl deaths. And we're also giving out a lot of naloxone at the same time. What do we make of this correlation? It's very difficult. Law enforcement data is fundamentally endogenous to our policy priorities because, what's the easiest arrest that you can make in America, would you say? Arrest for drug buying and selling. That is the easiest thing to do. We have overdose mortality data, which is the numerator of something, but we don't know what the denominator is. And we have data from social media, we have web searches, we have a bunch of things we can look at, but that they are proxies, and that are very difficult. So I say my kingdom for decent data and infrastructure. And we also have this problem that we have this really complicated epidemic going. We have this stock, and we have unintended consequences of many of the things that we try to do to control it. So Eric mentioned the stock and the flow to start out. The best policy to slow down the flow of new people into opioid dependence is not a very good policy to effectively help the stock of people who are already dependent. And so things like ratcheting up PDMPs, that's a prescription drug monitoring program, shutting down pill mills and then not engaging the people who were using that pill mill into treatment, tremendous social costs to those kinds of activities. And we really don't know how to study that. Also, most overdoses are not fatal. And so when we look at one of the challenges we have as a public health community is we often talk about the number of reversals that we've made using naloxone. And we don't know what to make of that because maybe 93% of all overdoses would not be fatal anyway. But we do know that there's a very high subsequent mortality rate among people who have a non-fatal overdose. This is a paper by Olfson and colleagues. There's about a 7%, 778 deaths per 10,000 person years after a non-fatal overdose. That's a 7% death rate per year. There's also the suicidality issue. So we have tremendous challenges to try to understand what's going on when we can see things like naloxone reversals, and we can do agent-based modeling, things like that, to try to understand it, but it's very imperfect. So how can we talk across communities about this? A couple of points I would make. One is, I think we all need a much greater sense of humility about what we know and what we can promise that we can do about this epidemic. I think if we follow the most effective policies that we know how to follow, that thousands and thousands of people will die every year from opioid overdose if we do a great job in terms of what we know how to do. This is not like HIV transmission where we really can slow it down dramatically using a simple technology. That we're just not going to be able to do that. And so anyone who claims that we just have to follow the data and do, it's obvious what to do, that I really distrust that. And when we think about the different communities involved in this conversation, we have to figure out ways to really emulate the best parts of each community and to not emulate the worst parts of every community. And when I think about the dialogue that Jennifer's been in and I've been in and others, it's difficult. It's difficult. It's especially difficult because we're in, and it's funny, we're in a golden age of economics right now. Like when I think about the ban the box paper, for example, that Jennifer did, that's the kind of research that is so much better than economics was doing 25 years ago. The empirical revolution, the use of big data. 25 years ago, everybody was looking at the current population survey and doing the same, or the same fundamentally removed from policy analyses compared to what people are doing now. But that's created some real dilemmas for us. Because economics is so ascendant, and people look to it, and in a lot of ways. So, and then if I think about the public health community, one of the things that we need to learn in the public health community from economics is greater attention to causal inference, even when this leads to uncongenial findings. There is a kind of confirmatory and sometimes self-righteous instinct that we as a public health community can bring to questions that we need to guard against. And we need to be much better at working across ideological and partisan lines. And earlier today, we were talking in this Hippo conference we were having about how there are many conservatives involved in drug policy who are very, very motivated by the redemptive aspects of addiction treatment to help people who have gotten involved in problematic behaviors and are trying to change. And we in the public health community need to be in that conversation and know how to talk to people in a positive way who are motivated by those sorts of normative beliefs. And we're very monochromatic in terms of our own culture and political perspectives, and we need to worry about that. And we need to be also restrained in what we claim harm reduction can do, and in particular to pay great attention to implementation science. One of the sad things about the needle exchange debate as I experienced it was that we spent a ton of time trying to justify the basic propriety of helping drug users and of the value of syringe exchange and the importance of syringe exchange. And we were stuck in this knife fight with people who did not mean well towards people who inject drugs. And how do we win that basic battle to get this stuff done? That was just what you had to do. It is very hard to do that and also say, by the way, let's also critically evaluate what are the ingredients of an effective harm reduction intervention? What are the nuts and bolts so you're doing this well? Are we connected to treatment? One of the challenges we had is it was kind of a renegade thing. The people, the pioneers of syringe exchange were often very countercultural. They were doing stuff, being very entrepreneurial and going out and pushing the envelope in places where this was not welcome. And bless those people for doing that. It is very difficult to do that and also be really programmatically integrated with the local methadone program and to do that in a bureaucratically effective nuts and bolts way. We also sometimes take our eye off the ball about the need for data infrastructure so that we can evaluate what's really going on. How many people right now are making non-medical use of opioids? We really don't have a good way to tell that. We have the National Survey of Drug Use and Health. Anybody know what that used to be called to respondents? It used to be called the National Household Survey of Drug Abuse. We used to go to people's houses and say, we're going to ask you questions about your drug use as part of the study called the National Household Survey of Drug Abuse. Would you be amazed to know that we dramatically underestimated the amount of drug use in America and specifically did not sample the people at highest risk? And so we are not touching the people who are the most likely to die of overdose through these things. Now on the other side, the sort of economics and policy analysis community, I sort of have a foot in both camps. I think much greater attention and sensitivity to the historical and social context is is mandatory, and particularly to understand what people with lived experience on the front lines of this are, uh, what their insights are. And, there's an arrogant impulse that we in the policy analysis community have that can be detected a million miles away. And, I've never seen a case where I've seen a really elaborate analysis that I've done or anybody else has done where the people in the clinical front lines or drug users say, this just doesn't ring true to me. That's turned out to be right. I don't think I've ever seen in my entire career an example of that. And we have to be attentive to that and be restrained about the kinds of causal claims that we make because we have such limited data. And understand that we have real power in the policy conversation. The words that we use, the policymakers are listening to what we have to say. And so it's important to get it right. And people are going to be angry at us if we don't get it right because they know that what we say matters. We're in a society that has a very tenuous commitment to the well-being of drug users. And people are right to say, you've got to be careful in that context. Just Susan Moffett earlier today was talking about the fact that we participate in a long multi-level conversation. I'm often in a seminar room where I'm like, hey, I want to talk about the data. There's all kinds of stuff going on. I just want to talk about the data now. You can't do that. No conversation is context free. And we're always having a conversation about causal inference and policy analysis. And we're also always having a moral conversation about the propriety of drug use, about the propriety of drug users and of helping them, and what we make in a society of the social justice claims that drug users may have to our help. And it's hard. So I look forward to hearing Jennifer's remarks and then to have a broader conversation with the crowd. Thank you so much.
Thank you. So I decided to forego the crutch of the slides because I don't have fancy figures or tables. So I figured I could just talk. So I might regret this, but we'll see how. So I'm going to start with just some reflections on working in this area as someone who has come to work on opioid-related policy relatively recently, and then talk about a review I did recently for Brookings that Eric mentioned at the beginning and kind of what our punchlines from that were. So I'm an economist by training, but most of my work is on crime and discrimination. And so my academic interest in the opioid crisis and opioid abuse stem largely from its intersection with prisoner reentry and effects on criminal behavior more broadly. So I'm a bit of an outsider to the public health research and policy space, and that's led to a bit of culture shock at various points, including some very heated online conversations. Starting this spring after Anita Mukherjee and I released a working paper about the effects of broadening naloxone access on opioid use. So I really appreciate that Eric suggested this panel. I appreciate that Harold agreed to join. And over the next hour or so, I really hope we can figure out how to work together productively to chart research and policy going forward. And as Harold mentioned, the upside of having scholars from multiple disciplines as part of any policy space is that we can benefit from the skills and expertise that each of us bring to the table. There are lots of people with far more institutional knowledge and on-the-ground experience than I have when it comes to medicine and public health. But I do believe that economists have a lot to offer in this space, both in terms of theory and empirical methods. And also, I mean, while I tend to think of myself as being pretty good at talking with non-economists, at least relative to most academic economists, I've completely failed to have productive conversations with a large number of public health researchers who care deeply about this issue. And that's something that really bothers me and that I really want to figure out how to fix. So a little bit more background on how I came to be on this panel today. As Eric mentioned, Anita Mukherjee and Molly Schnell and I wrote a post for the Brookings Institution in December reviewing recent research on the causal effects of policies related to opioid abuse and mortality. So we found ourselves as researchers investing a lot of time and energy in wrapping our minds around what's really been an explosion of recent work in this space. So much new good stuff coming out. And we figured if we were going to spend time synthesizing all this new research, then we might as well write it up so that others could benefit from that effort as well. That turned out to be easier said than done. It takes a little bit of time to get a sense of what all these papers say. It takes a lot more time to summarize it in 1,500 words that we could all agree upon. But we know that policymakers are really hungry for evidence in this space. So we figured it was something small we could do to help. Now, all three of us are economists. Most, but not all, of the studies that we reviewed in that piece are also by economists. We got a lot of pushback for this. People accused us of ignoring a broad public health literature, much of which has reached different conclusions than the papers that we did include too. Now, keeping up with an interdisciplinary literature like this is a fundamentally challenging endeavor, right? It is like, it's hard enough to keep up with your own discipline and much less read. I mean, it's hard to know what journals to read in other disciplines and so on. I spend a lot of my time reading papers outside of economics. I do a lot of, as I said, a lot of work in prison reentry. So I spend a lot of time reading papers that don't kind of meet the empirical bar that economists come to expect. But I want to make sure I don't miss the needles in the haystack. This is something I do care about, and I try to do a lot of that. But my sense from the conversations after this post went online is that our different takes on this literature really mostly reflected an underlying disagreement about the importance of causal identification. Yes, there are lots of papers on opioid abuse that we didn't cite, but those papers were typically descriptive in nature. And as an economist, I view that work as hypothesis generating. It can give us good ideas about what programs to try, but it can't tell us what the impact of such a program is going to be. I really believe that rigorous program evaluation is sorely needed in these policy conversations, and so those were the studies that we were trying to highlight in that book. It's been really interesting to me how many people suggest that rigorous evaluation isn't needed here because those on the ground know what we need to do based on their personal experience with patients. But lots of well-intentioned policies don't have their intended effects. And many also have important unintended consequences that can undo some or all apparent gains. There's no reason to expect that public health is going to be immune to those challenges. And it's really amazing to me how many public health researchers I talk to who think that unintended consequences won't happen. And it's like, it happens everywhere. And so I really strongly believe that if we care about helping the people and communities ravaged by addiction, it's crucial that we rigorously evaluate the policies and programs that we try. It's also crucial that we avoid getting attached to any particular program until we know what the impact is. There might be an alternative policy that could achieve bigger benefits. There might be other policies that turn out to have important complements and mitigate unintended costs. Or the policy that sounded great might just completely backfire. We might have just been wrong and missed some important context. So I've heard from many public health researchers that they think my work in this area is dangerous because it discusses the trade-offs inherent in harm reduction efforts. Real lives are at stake, they rightly point out. But to be clear, I think it's far more dangerous to make policy in this area based on anecdotes and gut feelings. If we wind up concluding that our best empirical methods or data systems can't be relied upon in this space, then that would be a really terrible outcome. It would leave us making policy based on faith rather than evidence. So it turns out with the blog post, many members of the public health research community launched a campaign to get Brookings to retract the post. I appreciate that Brookings stood by us and stood up for our academic freedom as researchers. But the external pressure meant I spent a lot of time going back and forth with their communications team trying to figure out whether and how to respond to the criticism we were getting. I have a pretty thick skin, but it's working in this area has been really stressful. And frankly, the vicious attacks in response to my work over the last year have left me inclined to work on anything but public health. I know I'm not alone. Many other junior economists have told me that they've considered abandoning projects that they don't want to deal because they don't want to deal with the potential backlash from the public health research community. That is not a good equilibrium to be in. We need lots of smart people with lots of different perspectives working on these issues. So I'm going to talk now about the actual the punchlines of that review that we put online. So we divided the studies that we found into 6 broad categories. We have studies looking at reducing the quantity of opioids available, targeting the black market, harm reduction strategies, increasing access to substance abuse treatment, alternatives for pain management, and reducing demand for opioids. Just like categorizing stuff felt like a big challenge here. So many trace the current crisis to the overprescription of opioids. And so a wave of legislation has really focused on reducing opioid prescriptions by medical providers. There's a paper by Mira et al. From 2016 that considers the effect of a wide variety of state-level policies in this space. Basically, their team finds no effect of any of those policies on anything when they look at the impact on prescription opioids received by a sample of Medicare recipients with high opioid use. So that was a disappointing result. It certainly highlights how difficult it is for policy to change behavior. That said, those average effects really seem to mask heterogeneity. So for instance, more recent research on prescription drug monitoring programs, or PDMPs, this type of program has been particularly a big focus of a lot of papers in recent years, finds that there are 2 broad types of PDMPs. There must access PDMPs that doctors are required by law to check before they write a prescription, and basically shows all the previous prescriptions the patient had received. Or they're voluntary access PDMPs that they can check if they have a suspicion, but they don't have to check it. So basically, the research has shown that the must access PDMPs reduce prescription rates in opioid abuse, but voluntary access PDMPs have no effect. So in other words, requiring doctors to check the database before writing a prescription really seems to be important. Now there are trade-offs here. So work by Justine Mollett suggests that reducing prescription access to opioids through PDMPs causes some users to switch to heroin. They can't get the prescription pills anymore. She finds that heroin-related crime increases when PDMPs go into effect. And this speaks to an unintended consequence of this policy on drug use that is obviously going to be important to pay attention to. It's not simply going to be as easy as stopping the flow out of doctors' offices. There are other ways to potentially change prescribing behavior. So there are a few different experiments involving behavioral nudges that are kind of interesting, as well as some research on education. So it turns out that changing the default prescription amount in a computer system can shift prescribing behavior through. So basically, if you have the default dose is a certain number of pills, you can lower that a little bit, and maybe everyone will get fewer pills. The problem is it could be sensitive to exactly what the default is. You can override it, so it's going to require some trial and error there. Another experiment showed that feedback to doctors about their patients' outcomes was really effective. So doctors were randomly assigned to receive a notification of a patient overdose or not, and those that received the notification prescribed 10% fewer opioids in the next 3 months. Now, the next question, of course, is what would happen to mortality? What would hope to happen to opioid use? And so those are the sorts of next questions in the space that will be interesting to pay attention to. It also turns out that differences in prescribing behavior vary across doctors who attended different medical schools, but then practiced in the same clinic or the same specialty. And that suggests that the initial training they received is really important here. So again, the big potential trade-off in all of these efforts aimed at reducing opioid prescriptions from doctors is that some patients with legitimate pain might not get the treatment they need. So some former patients will turn to the black market, buy heroin perhaps instead. And so studies that consider the broader population level impacts of these kinds of interventions will be important for understanding the net effects on opioid abuse. And so speaking of the black market, kind of the next thing we looked at was potential interventions here. This going after the black market really, I think, for many of us, raises kind of the war on drugs type of imagery. Maybe we could do something like we could really target drug dealers, and maybe that would be effective. There's not quite as much work on that because I think there's no political appetite for that. But we do know that a good amount of the prescription opioids that are prescribed do wind up being diverted into the black market. And so as our experience with the war on drugs suggests, certainly making any sort of meaningful impact on the black market is easier said than done, can have unintended consequences. Work by Molly Schnell shows that physicians are already being more cautious in their prescribing behavior because they know that some of the pills they prescribe will be diverted to the black market. So you can imagine that if we were somehow to magically shrink the black market, that could actually backfire and that doctors will be more liberal in their prescribing. In addition, there are a few different recent studies that show the effect of the reformulation of OxyContin, which is one of these prescription opioids, to make it tamper resistant and thus more difficult to abuse. There are two nice studies that came out about the same time that show that this change simply led those dependent on the pills to switch to heroin at basically a 1-to-1 rate. So that in the end, there was no net change in opioid-related mortality. And in addition, a more recent paper by Beheshti finds that it also led to the additional negative effect of increasing blood-borne illnesses like hepatitis B and C. So because they were using heroin now instead, they were at risk for these other problems. And next, we talked about harm reduction policies, and this is, of course, where things get really contentious. Economic theory predicts that when you reduce the expected cost of engaging in some activity, people will engage in the activity more often. Most economists would therefore predict that any policy that reduces the negative consequence of drug use, be it stigma or risk of death, any policy that reduces the negative consequences of that drug use will increase drug use. So to economists, the direction of that effect is just unambiguous. It seems obvious to us. The question is what the magnitude of the effect will be in a particular context. And so this is a place where it turns out public health researchers strongly disagree with economic theory. And so that makes the impact of harm reduction policies a really interesting and important empirical question that we need more research on. So I have a paper with Anita Mukherjee that looks at the effects of broadening access to naloxone, which can save your life if it's administered during an overdose, on opioid abuse. And we find evidence that it increases opioid abuse and has mixed effects on mortality rates. In the Midwest, we find that opioid-related mortality increased 14% due to these law changes. The intuition here is that now that the risk of death has fallen, users may use more often or use more potent forms of opioids. That could be that they're actively seeking out things like fentanyl. It could be that they are just being a little bit less careful about the source of their heroin and whether there's fentanyl mixed in with it. And we heard a little bit earlier today about fentanyl testing strips. And so this is a place where more research will be really helpful, because if it turns out this is actually a mistake and people are just being less careful, giving everyone fentanyl strips could solve that problem, right? If they're actually seeking out the fentanyl, that's harder to solve. A more recent paper, I think it just went online yesterday or today, by Annalisa Packham and Catherine Wells, considered the opening of syringe exchange programs across the country in the United States. They find reductions in HIV rates, which Harold mentioned. Other studies had found that big benefit. That's consistent with the previous work on this topic. But there is, I think, is the first study to measure the effects of such syringe exchange programs on opioid use. And they found that opioid mortality increases as the result of opening syringe exchange programs. So they argue that this is, again, a classic economic story of what economists call moral hazard, where people compensate for the reduction in risk by doing more of that now less risky behavior. So in my paper with Anita, we find some suggestive evidence that access to substance abuse treatment can mitigate the unintended consequences of broadening naloxone access. The intuition there is that if you save the life of someone who's overdosed, the hope is that you would give them a chance to go seek treatment and kind of get on a better track. If there's no treatment available, then it's maybe perhaps unsurprising if you don't wind up seeing big benefits. So that results, in addition to a few other studies looking at the impact of substance abuse treatment, really, I think, highlight the importance of pouring more resources into this area. So several studies show that increasing the availability of drug treatment reduces drug-induced mortality as well as crime rates, which suggests that a good deal of crime is driven by drug use. These effects have been found in papers that look at the openings and closings of facilities, drug treatment facilities, as well as the impacts of Medicaid expansions that provide easier access to and cheaper healthcare in this space. What's interesting to me is that there's the medication-assisted treatment comes up a lot in public health circles. So methadone, Suboxone, those sorts of things that can help someone stay off of or avoid using heroin and other opioids. this seems really, I mean, I think that in the public health space, they view this as this has been proven that this will help. I view it as extremely promising. My prior is that this would be extreme, like we should be flooding the streets with this. But it is controversial in the United States, and unfortunately, there's no current evidence that the large scale availability of such treatment would affect opioid use or mortality. We just don't know. Those studies have not been done. And so that's a place where I really think we just urgently need rigorous research, both to understand who would benefit from access to that kind of treatment, to understand how big the effects would be, and whether there are any unintended consequences that we might not be predicting. The last two sections of this were really about kind of trying to get people to reduce their demands for opioids. So we could imagine providing alternatives for pain management. If a large share of opioid addiction is the result of patients becoming addicted after legitimately using prescription opioids to treat pain, then providing less risky ways to manage that pain could be helpful. And the main thing that's been studied in the space is access to legal marijuana. So it turns out that a couple different studies have found that medical marijuana laws reduce prescriptions for opioids, reduce admissions to drug treatment, and reduce opioid-related mortality. So the effects are larger in the states with active marijuana dispensaries than in states that simply allow home cultivation. So this suggests that the ease of access matters, which seems intuitive here. Another way to potentially reduce demand for opioids is to increase the price, right? This is what every economist would. I'd be remiss if I didn't mention that potential option. Demand for opioids is responsive to price. There have been studies that have shown that, but of course we worry people who legitimately need this medication for pain management are just going to be paying more. And there's also this really interesting study from Moore and Schneppel that found that a really dramatic price increase for heroin in Australia led to an equally dramatic reduction in heroin use in that country with really long-term benefits, which is just, it's fascinating, but it's also really hard to imagine sort of recreating that in the United States. There is some discussion in the literature that I think came up a little bit earlier, the idea that there are economic factors that might affect opioid abuse. This is the deaths of despair argument put forth by Case and Deaton. My read of the literature on this is that the evidence is pretty mixed at this point. It's not really clear how much economic factors are driving these decisions. But some studies do find that improving local economic conditions reduces opioid abuse and mortality. That said, policymakers surely already have many reasons to try to generate economic opportunity. So this might just be a policy lever that's out of their reach. So that's our whirlwind tour of the evidence that we put up at Brookings. It's a snapshot of where the literature stood at the end of 2018. I think the big punchlines here are that must-access PDMPs reduce prescribing and abuse, but may push some into the black market and or limit pain treatment for those who need it. And harm reduction programs can improve some outcomes among those who are already addicted, but at the cost of encouraging riskier use. So to mitigate that unintended consequence, I urge policymakers to pair harm reduction strategies with broad access to substance abuse treatment and alternatives to pain management, including legalizing marijuana for medical use. New papers in this space seem to come out every week. So this post that we put online will soon be outdated. But I do hope that this synthesis helps clarify what we know so far and points to new research and policy directions. I'll leave it there.
So in a couple of minutes, we'll open it up, but I did want to give Jen and Harold a chance to engage one another about their respective comments. But before I do, I just want to reiterate how grateful I am that both were enthusiastic about participating in this panel. It was motivated, I think, originally by my sense not only that the opioid epidemic is so important and that Jennifer's paper on naloxone was stimulating important debate, but also the broader issues that have already been touched upon, that if we're going to promote two goals that I think everybody here shares, which is scientific progress and problem solving, we're going to need the talents and strengths of different disciplines. And that is often a struggle to bring people who are trained differently, who use different methodologies, who have different assumptions together. And if we can find ways of making that collaboration more productive, I think it'll be good for knowledge and good for society. So initially, do either of you want to make any comments about one another's remarks?
Well, I'll just say, I'll be brief. I was just before I came to Brown, I was at NIH as on the studies section for the new HEAL initiative, which is a very ambitious and costly effort that where some sites will be selected to do a sort of full court press on the order of spending potentially $150 million in a particular region to see what can be done to reduce opioid mortality. And the goal of this is a 40% reduction within 3 years of opioid overdose death. I do not believe that that is going to be achieved, but I think as a stretch goal, it's something that certainly is a good aspiration. What struck me about the really strong applications from across the country is how many people were very attentive to the issues that you noted about how harm reduction needs to be combined with efforts to engage people in treatment, and also how treatment has to be linked with harm reduction. Because, when people are in opioid disorder treatment, there's still some level of use. And overdose prevention within that context is critical because we know that people will reduce their tolerance, and things like naloxone distribution to people in treatment is actually quite important. And the attention to implementation science and rigorous evaluation to do truly, I think it's an open question, both what naloxone accomplishes and also what the policies designed to promote naloxone do to actually get naloxone out there. One of the challenges we have is I think we don't know, I don't think we have a way to really know how much we've really increased naloxone distribution on the ground. And I think there is a melding of perspectives through implementation science that will make this dispute less extreme as we move forward, because certainly people in both communities understand a lot of the insights offered by the other, even though we often use different language to talk about it.
I think the main comment, you hear me? Okay. Is that I think one of the real insights that came out of the most recent discussion from the Brookings blog post was that I think I hadn't really fully absorbed before, was how much history there is in this policy conversation. And again, because this is not a space I usually work in, it became much clearer that a part of the reason that I think we were talking past each other was that a lot of people who work in public health hear my calls for more and better research as insincere excuses not to do anything. And that is definitely not why I call for more and better research, right? I mean, my calls for research are truly coming from a place of, I think there's a solution out there, and I think we're wasting time if we're not testing things. So I think understanding the history in this space has been really helpful for me, and I think that's I'm not sure what the obviously everybody should make an effort to do that, but it is hard in practice to understand the history of everything you're working on going in. So I think to some extent playing a more helping each other out in understanding the different contexts, I think it can go a long way.
So both of you have alluded to the importance of better research, and I noticed a year or so ago the New York Times Upcut column ran this very splashy big piece with all of these fancy figures, and they asked 30 experts about to think big but realistically, that if they had $100 billion to spend to fight the opioid epidemic, what would they do? And all of these people came up with different ideas. Many of them we've talked about today. Mm-hmm. But I'm wondering, in some ways for this conversation, a better question would be to see if you have any ideas or even how you would begin to think about it. Not if you had $100 billion to solve the problem, but if you had, say, $10 million to research anything that you think would be appropriate around learning more, what would be the kinds of things you would begin thinking about? What kinds of methodologies do you think would be an improvement over what we're doing today? What kind of data would we need to advance knowledge in this space?
Yeah, I mean, for me, the first thing that comes to mind is studying the effect of medication-assisted treatments and other types of substance abuse treatment, and looking at one of the things that I find frustrating in reading a lot of the studies is even when you have nice randomized controlled trials, the outcomes that people look at is usually like self-reported drug use, and economists don't like surveys, so I just I never know what to make of a survey about whether the self-reports. It just always feels like it's going to be biased toward finding beneficial outcomes. And so doing either nice RCTs if you can pull it off, or just or doing something with more of a natural curve, but using admin data on outcomes that we think are likely to improve. So whether it's employment, whether it's criminal justice involvement, but being able to just get the admin data so that we can know for sure. I think that's how I'd spend the money. I don't know why you're reducing our budget.
Suddenly went down to 10 million.
Yeah.
I mean, I took a negotiation class. That seems like I certainly would want to see, I mean, most of my work at the University of Chicago Health Lab and Crime Lab is using administrative data in RCTs. So I'm certainly a huge fan of doing that, and that's what we do most of the time. I would say that to couple that with understanding the human face of what's going on with these drug users. And I think economists distrust surveys for some good reasons and some bad reasons. And I think the good reasons are that I agree that the self-reported outcomes are often misleading. And we know from HIV prevention, if you give out condoms and then ask people, are you practicing safer sex? Yes, I am. And harm reduction is a great example, by the way, of a somewhat unpalatable harm reduction intervention. It's a lot less attractive to use a condom than it is to use a nice, clean, sharp new needle if you're a drug user. I've never known anyone who's been enthusiastic about that. I think some of the cohort studies of people like Susan Sherman in the public health firm, not just to ask are you engaged in less risk behavior, but how do you use the syringe exchange? What is it about the syringe exchange that either makes it helpful or not helpful? What are you thinking about treatment? What is it about the content of? One of the problems we have with treatment is it's not very attractive for people. And we often talk about how we have to make treatment available for people. We have to deal with the access problem. A big part of the access problem is it's not a lot of fun to go to treatment, and it's a pretty demeaning experience for a lot of people. And if I said to someone here, you can go down to the county health department and sign up for a methadone program because you got in trouble with some pain relievers, a lot of the people in this room would think of a lot of reasons why they were not going to go down and do that. And I do think that understanding the human face of this and combining that with the implementation science is critical, because it's not just, are you offering MAT? Are you offering MAT in a way that's really going to engage people and retain them? That's the kind of information we need about mechanism, about human experience of it. And I think, by the way, the economics profession is getting much better at this as we do RCTs, because we're actually out there doing stuff. And you see things when you're doing stuff that you don't see sitting in the basement of the Harvard Science Building running a data tape. And programmatic sophistication is really important.
Another question is, there's inevitably going to be a healthy debate between people in different disciplines, and they're going to bring different strengths to the table, and they're going to have different viewpoints. And sometimes those clashes will be somewhat heated, which is a reflection not of any bad faith, but simply that people disagree or have different takes on the data or have different standards of evidence. How can those debates play out in an issue like the opioid epidemic, where the discussion is not simply being followed by academics, by researchers, but also by policymakers and others who are coming at these questions from a very different perspective? It's very hard in the era of social media to sort of say, well, this is a dialogue among researchers, and we'll let you know when we sort of have reached a consensus, so don't pay any attention to us for 6 months. We'll be back to you. That's not really realistic. Is there any way that we can find the space for these debates while also making sure when researchers do speak to policymakers, it's in a way that they can absorb and understand and bring about effect?
I mean, my perspective is informed a bit by most of my work in the policy space is not in public health. There, the conversation is totally different. It feels much more respectful, frankly. I mean, it just feels like people do disagree, but there's something about the social norms in the public health research community that make it acceptable to just viciously attack the motives of researchers, and that is not a good equilibrium. And as I said, it makes me want to work on anything else. I know there are a lot of spaces. I do a lot of work now on prisoner reentry. I think a lot of the really important questions are around to what extent mental health treatment or substance abuse treatment could help people reintegrate successfully when they come out of prison. We know almost nothing about that. My hunch is that's where the big wins are going to come from. And I have really mixed feelings about engaging in any project that are gonna be in that area myself, because it's so unpleasant work. So I feel somehow other research areas have figured this out. I don't know why it's hard in this.
Well, I think there's something to that. I think there's also something to the idea that the economics and policy community brings a kind of arrogance to the table and a credulity about the data that we have, that we can bring a set of powerful econometric tools to very limited data, and then and I think that a lot of us, I mean, I just don't agree with the analysis that in the original paper that brought out the debate that we did. I do think that it got nastier and more personal than it needed to be. But I think that there has to be more of an appreciation of the strengths of all sides in that. And I also think, and I do think that there's something about the unique position of economics that puts us all in a very awkward position. If I ask a bunch of economics graduate students, tell me who the leading sociologists are who are studying the things in your area, they won't know. And they don't have to know. If I ask sociologists who are studying the same area, who are the leading economists in your area, they do know, and they have to know. And they know that in the policy conversation that we look to the econometric analyses as having a particular status in the policy conversation. And because of that, that creates a real dilemma for people on all sides of this. A lot of the history that you describe, which does make it a very nasty thing. When you were walking into a historical conversation, when I went through policy analysis training, I was certainly never taught it's really important for you to understand that history and to understand who the stakeholders are and how certain words and certain constructs, like moral hazard, for example, will be interpreted by people who feel very directly that there are connotations to that they find very problematic. So there's a lot of cultural competence across these disciplines that is required on all sides. And as I said, I do think that to personalize it is, of course, we live in a Twitter world where everybody insults everybody, and we do have to move away from that. But I think that there's some real substance underneath that on both sides. There's going to be tension, and there's going to be legitimate disagreement, and there's real stuff at stake. And I understand why people are very passionate about it, because I lived through a long policy history in which people who inject drugs had their fundamental needs left very willfully unaddressed, and the belief out there that a very strong stigma against people who use drugs was actually a socially beneficial thing, and that making it, and the things that we do that make drug use too easy would have negative consequences, and the human consequences of that construct were incredibly harmful in HIV and in other areas. And of course, people are going to bring that to this debate because that's the life experience of the people that are the most intimately affected by this problem.
Let's open things up. There'll be a mic passed that Jen will have. So just raise your hand if you'd like to be recognized, and then Jen will bring the mic.
Hey, thanks. I'm Dave Eagleman, as of today, still a faculty member in family medicine. I'm putting together the case for the MDL in Cleveland against the manufacturers, and I'm concerned that you're missing a major source of data, because all these studies have been done by the company. They figured out return on investment for how to change physician behavior, and you didn't mention any of the things that they did or continue to do to sell, or the things that they think will discourage that. For example, detail reps, lottery ROI, influencing formularies, and controlling formularies, PBMs, trips to Hawaii, brothels, use of sex generally, which you obviously you can't do that, but you might consider just only admitting women to medical school. I've made that recommendation in Africa often for a variety of reasons. Bribes, small and large. The Ciandali studied that very well in marketing. That means a pen makes a difference. Piece of paper makes a difference. A little pad makes a difference in terms of physician behavior. They've studied that. Gifts, same thing. State medical boards. As you know, the pharmaceutical companies got the state medical boards to make it mandatory to take training in prescribing and reverse the penalties. The penalties used to be if you overprescribed, you could lose your license. They passed laws and state medical boards changed rules that said that if you underprescribe, we will take your license away and we will never punish you for overprescribing. Same thing with the hospital commissions. The JACO was completely corrupted by Purdue, so they made paying the fifth vital sign. And the fifth vital sign was a reason that Killing with Kindness is the relevant article that showed the increase in mortality after the Killing with Kindness program was adopted by JACO. So you haven't mentioned state medical boards or JACO. Just in terms of therapy, historically the most effective therapies are group therapy, and the companies did that. And then the last and most important is jail time to motivate pharma. It's time to put some rich white people in jail for killing these people and for knowingly marketing things that would kill people. And until that happens, pharma's not going to be doing anything. But if you want to see pharma move, every death, every day is a new manslaughter case. And you know, you can arrest bartenders, go get convicted for over giving drinks at a bar. So that's enough.
Prescription drug of the available empirical research on I think that we brought that was I certainly agreed with your comments in that part as summarizing the available literature well, and then clearly the misconduct by the industry, which is not particularly the focus of this talk, but I think it is obvious that there was criminal misconduct by the pharmaceutical industry, Purdue and others, that played a fundamental role in generating this. And by the way, and then when we do things to try to stem the flow of that, the impact on that on many communities is quite severe, because when you ratchet up the PDMPs and other things and people substitute into heroin, they then join the ecology of the heroin market, and places like Providence, New Haven, then bear the social costs of having the heroin market and the street drug market accelerated by the misconduct of the industry. And certainly that would be a whole different conversation, but it's clear to me that the industry has tremendous culpability for a whole variety of things that increased opioid death. And some of that was certainly, I think there's a lot of well-intentioned efforts to control pain by a lot of people, but they're clearly, Purdue and others knew very, very quickly that there was this tremendous underground market growing, and that is, I think everyone across the ideological spectrum at this point would say, wow, that was a major, that sort of tobacco company type of misconduct that has to be systematically addressed, including through the criminal process where appropriate.
Hi, I'm David Scarbeck. I teach in political science. I really enjoyed both of your talks. I guess my question is for you, Jennifer, on sort of this methodological discussion that we've been having. I'm a great fan of your work and a big fan of the causal inference work in crime, and it's a really exciting time to be reading all these papers. And it seems, however, that when I read them, I often get the sense, especially when they're dealing with more aggregate level data, that they're telling us what happened, not why it happened. And if you think there are a number of different mechanisms that connect X to Y, and we might call them causal pathways, and so if there's more than one, then knowing what happened doesn't tell us why it happened. And that would seem crucial for laws, policies, interventions to try to address those things. So my question to the economist, I guess, is, given, as you noted, that economists don't typically do descriptive work, and they don't deal with qualitative types of evidence, how do we get which of the many possible mechanisms are underlying some causal effect?
My general feeling about this is where the complementarities between the disciplines really becomes most useful, right? I mean, basically, when I say that this descriptive work is hypothesis generating, that's not to say it's not important. That's extremely important. That's where our hypotheses come from, is that like seeing, like talking to people and figuring out, reading. In crime stuff, it's mostly like reading sociologists. They're the ones who have like given us all that good material. The best causal research in econ tries as hard as it can to nail down what the mechanisms are. It's often just really hard. You change a policy and you change 10 different things, and ultimately you can lay out hypotheses about which mechanisms you think are most important and look at different data and see, to what extent the data is consistent with this one or that one. But ultimately, what you can nail down is the overall effect of the policy. And so economists are very careful to sort of like upfront about like that's what this effect is. And then the next paper tries to find a way to get the mechanism a little bit better. I think this is just how literature's developed. But yeah, overall, I think this is just how we need to talk to each other, because like I don't know how to do qualitative work, and I probably will not learn it. So so I need to read other people's work.
By the way, NIH is quite aware of the importance of mechanism. One of the striking changes at NIH is that if you want to get NIH funding for a randomized controlled trial, you have to be able to elucidate mechanism and what are you measuring that's going to allow you to identify mechanism, and what's the causal pathway, and show us the variables that you are moving so that you can show that that is the credible pathway. And the sort of days of the black box RCT are numbered, because a lot of us have done those, and what NIH and many policymakers are saying is that it's not helpful to know that this intervention worked. You've got to be able to, in order for that to be replicated, in order for us to truly believe that we understand what happened in that study, we have to see mechanism and see that you've laid it out ahead of time explicitly, and that's a really positive. It's very demanding, because in our studies we often have a very difficult time showing mechanism, and certainly I have the scars to prove it in NIH scores. We like to complain about the bad reviewer comments, but with the ones that I really hate are the good reviewer comments that I don't have a great answer for, and I think implementation science and mechanism and thinking about the full causal pathway is the way that we're going to do that. And sometimes that involves qualitative research. Sometimes it involves just different quantitative methods that get to that pathway. But increasingly, we're being held to account for that.
Jody Rich, I'm looking at the Portugal situation, where 18 years ago they had the worst rates of injection drug use related HIV, among the worst rates of overdose in all of Europe, and a lot of incarceration and a lot of crime related to drug use. And they decriminalized possession of drugs. So still selling drugs is illegal, and they took that out of the criminal penalties. They're still civil, I would call them coercions, to get people into treatment, and they expanded access to treatment. Then fast forward 18 years later, on all of those metrics, crime, incarceration, injection drug use related HIV, they've gone from the worst in Europe to just about the best in Europe. But more striking to me has been the decline in drug use overall. And so I think in this country we have a sense that, oh my God, this drug use is terrible, and we've got to hold the line, and at least we have all these laws, keeping them at bay to some degree. And my take on it is that drugs has been an abysmal, that, in working with thousands of patients who have this disease, having them arrested for a timeout is sometimes helpful. Having them serve time is a waste of time and disruptive of their lives and their whole families and their whole communities. And so I see I kind of think of, in public health, we think of an disaster as a have to deal with, but also a potential opportunity. And I think to me, there's many opportunities in this opioid crisis. One is to try and bend the bend the curve of this epidemic, get more people treated, or figure out how to prevent it, get some parameters on what the most effective treatment are. But I think another thing we can do is really take a step back and say, wait a minute, we are investing a lot of money, a lot of resources, a lot of time and effort, prisons and jails and courts and police, and distracting them from all the other important stuff that they should be doing. And we're not getting what we're investing. We are getting actually the opposite. We're making the drug problem worse. And I think my simplistic way of thinking about it is that whole apparatus that we've developed, which falls on Harold's notion of how we treat people with addiction, has really scared people away, has made them scatter and go underground and hide. And then we come up and we say, oh, well, hey, we got this great treatment. Come to a methadone program. Come to the county. Come to your doctor's office. Get some buprenorphine, Suboxone. And they don't trust it because why would they? Punished. So any potential solution to this problem obviously has to be political, and I don't see any way of it happening through the federal system. Willie Horton situation, caucus, any politician who gets up and says, we want to decrease incarceration is going to be accused of being soft on crime, and they're going to get voted out. So, but I think we do have an opportunity in the state to move in the direction of Portugal. So I just want to hear your take on that.
Yeah. So I mean, I generally agree, and I think one of the things I love about working on criminal justice policy is I actually think it's one space where there isn't like there's true bipartisan support for just progress. Like it's such everybody agrees that the criminal justice system is a mess, and there's so much work to do, and there's so much positive direction to move in that there isn't much time spent on partisan bats. It also probably helps that most of the action is not at the federal level, so we don't have to count on Congress to do anything, right? It's all state and local. But yeah, I think there really aren't that many people anymore who are really like tough on crime politicians. I think there's a lot of interest in redemption and from the more religious factions of the right, and then more libertarian parts of government see the big failed government program of prisons and jails, and so are happy to reduce incarceration costs. And so, yeah, I mean, I think going from criminalizing everything to criminalizing no drugs is probably not something we're going to do in this country, certainly not anytime soon. We're undergoing a national experiment when it comes to marijuana, and that is moving apace, and will be, I think everyone, as far as I can tell, the general feeling has been positive about how that experiment has gone. But yeah, I think I am very optimistic that there's a pretty broad consensus to criminalization of drugs.
Let me just add to that. By the way, Jody, thanks for the work that you do, and you're, someone who's been in the trenches, who's helped thousands of people, and that I want to honor that incredibly important work. I do think Portugal's a good example, and I think eventually we will decriminalize possession of small amounts of drugs for personal use. In Chicago, we do deflection interventions. I'm PI on a project called the West Side Narcotics Diversion to Treatment Initiative, and one of the striking things is the Chicago Police Department does not want to arrest low-level drug buyers or even drug sellers. They view the drug sellers increasingly on the street, who are the people that they arrest, as the hired hands, and they want to hand them over to a treatment provider and say, please do something so that we don't have to worry about these people. And when it's funny you mentioned Willie Horton, I was in 2008 I was the co-chair of the Obama campaign's public health advisory group. By the way, full disclosure, I'm a pretty liberal person, just in case there's, and when ACA was being formulated, there was a real concern that there was going to be a Willie Horton type politics. And around two issues. One was the substance use and mental health parity components of ACA, and the other was the ACA Medicaid expansion. Because if you think about one of the big groups benefited through the Medicaid expansion, it was guys leaving the criminal justice system. Low-income men not eligible for, who are uninsured and not eligible for anything else. And that has never happened. The Senate Finance Committee, all the Republicans who voted against ACA in the end, all voted unanimously for the substance use mental health parity components and have not attacked those components of ACA. And a couple of Republicans have put their toes in the water about going after ACA Medicaid expansion and the criminal justice population, but that basically has not happened. That has not been a political avenue that Republicans have chosen to pursue. And I think that's really interesting, that is not what they want to do. That's not what they view as a politically effective strategy, and it's not what they view as a strategy that they personally feel good about. And, everybody has someone who is affected by the opioid epidemic that's not too many clicks away from them. And so I am also optimistic about this. And this is not the culture wars of 20 years ago. And, we partly because we lived through that and we remember it. The opioid epidemic is in some ways a mirror on society. In some ways, it's a rearview mirror on American society. A lot of people are looking back on the crack epidemic and are saying, wow, we really messed that up. And we really behaved horribly as a society, and we should not do that again. And I think that is a part of the discourse, especially among younger people, but not just among younger people. And I honestly think we're going to make a lot of progress.
I'm Brandon Davis. I'm a political scientist in the Political Theory Project, but also a social worker. I'm an MSW social worker. I did direct practice and also work for the National Association of Social Workers. My question is about this concept. You keep saying treatment. And so treatment to me means that people go into counseling, therapy, they go to NA meetings, but it also means medication for those really addictive drugs. So essentially what you're saying is you're going to smack pharma on the hand and knock the opiates out of it, but then you're going to take with their left hand, you're going to get the methadone and everything else out of it. So how are you going to address the issue and bring those people who are responsible for some of the increase in opioid abuse, right? So all of it doesn't come from like doctor's office, but some of the increase. How are you going to hold them responsible if you're going to take money out of one pot and put it in another pot, the same companies? Because it's not like it's a huge market of pharmaceutical companies out there. It's not like it's like retail stores of pharmaceutical companies. It's like 6 or 7 that are making all this money, and they're going to get the same money back from the OD medicine and the methadone and things like that.
Well, first of all, I mean, pharmaceutical companies exist, and it's kind of they're gonna meet market demand for good things and for bad things, and it's up to us to regulate capitalist acts among consenting adults to make sure that they're doing the good things and not doing the bad things. It is medication assisted treatment, especially my first set of papers in this space were showing that high dose methadone was was a much better approach than low dose methadone for getting outcomes that we wanted for people. And I think we have to hold people specifically responsible for the misconduct around around OxyContin and all and so on. But I think we can do two things at the same time. And I think, by the way, the cost of medication-assisted treatment is a real problem. And one of the challenges we have is a lot of stuff is just super expensive for people. And naloxone is expensive, and a lot of Suboxone is expensive, and we have to deal with that. And there's a sort of separate regulatory and market industrial organization aspect. How do we do this in a cost-effective way? But I'm sort of okay with having people make a lot of profit if they're doing things that make people's lives better. I'm not so okay when they're making a lot of profit when they're destroying people's lives. And I want to And, I think we have to make sure we're doing more of the good stuff and less.
Big crisis taught us. The market materials from big caution, right? Like do our own studies and be careful about what the impact that they're reporting, making sure they're actually lining up with reality. But yeah, I think I'm of the same mind as Harold. It's like that, if it turns out this additional medication would help a lot of people, then withholding it because we don't want to give the profits to the guys who got us into this mess doesn't really feel like a viable option.
I think detailing is something we do have to deal with. I mean, I think direct marketing to doctors, clearly there's a bunch of abuses that were done in the OxyContin context that are broader that we have to deal with. And I do think, academic detailing and on some other strategies to make sure that we have unbiased advice to doctors is really important.
Did we misunderstand your?
Your pharmaceutical company is not an open market. If you're going to set the precedent where you'll let big companies create a problem that they then are the only ones that can fix it, then what's to stop another company from creating a big problem if they're the only person?
Well, some of the companies that did the specific misconduct will be wiped out. I mean, the MDL was I think that, by the way, I would predict that eventually all these Sackler plaques up all over academia and museums around the country, they will, at some
down.
point, those things will come down. And I think there will be specific accountability for this.
So it's 5 o'clock and we should end the discussion, but I want to thank again Jen and Harold for contributing to this. Oh, I'm sorry. Yeah. That would be fine. Sure. Whatever, Jen, do you have the mic?
First of all, I wanted to say that I'm sorry that you've been verbally eviscerated. That's just terribly unfortunate. I think it reflects the degradation of discourse in America, and it just sucks to be the recipient of that. So I want to just express my personal regret for that. And I really appreciate having people with different points of view sit together and have a constructive conversation about those differences. I'm really intrigued by what I heard, which I may have misheard, about the effectiveness of medication-assisted treatment. I'm a professor of social work, and I went to SSA for my PhD, so hello. My reviews of the literature on MAT indicate that it is more effective than treatment without medication. And I can appreciate the methodological problems in making that conclusion, because if the only outcome is death or not death, that's a kind of tricky thing, because we don't always know the cause of death. If we give credence to what consumers of treatment say is their experience in treatment, that is subjective data, which could be considered suspect or could be considered the best kind of data you got, so use it, right? So I just wondered if you could clarify your thoughts about it being ineffective. Yeah.
Yeah, no, and I didn't say it was that the research shows it's ineffective. I said that we don't know what the impacts are of kind of broad, large-scale availability of medication-assisted treatment, like basically just like making methadone widely available or Suboxone widely available to anyone who wants it. I think there have been like nice, very small RCTs, like clinical trials for a very small set of individuals, but it's ultimately going to be the longer term, larger scale effects that determine what the effect of policy.
I appreciate your clarifying that, because it's part of a larger issue that's been brought up a bit tangentially that I just want to highlight. That what is treatment? Treatment is many different things, and often treatment is limited to detox, which isn't treatment. As you pointed out, detox can increase the likelihood of death because it lowers susceptibility to the substances. And also, given that substance use is a lifelong issue, it changes the brain. So treatment isn't a thing that you start and end. It's sort of a lifelong thing. And we're not providing that kind of intervention for substance use. What we're doing is short-term things. And medication-assisted treatment means that medication is part of the treatment, not the treatment. So as Harold was pointing out, it's a very complicated picture.
Well, I think we have to make medication-assisted treatment. Have to offer it in a way that is dignified and accessible, and that and is critically evaluated in the same way that we would any other medical treatment. And we have to honor. I do think that we have to honor the dignity of people who use drugs and show people that they can lead better lives. By the way, they can lead better lives even if there's some level of drug use. The problem is, how are people taking care of themselves? Are they honoring their obligations to the people around them? And drug users can do that. One of the great things about harm reduction is that when you do syringe exchange and you do these other things, what you find is a lot of people who use drugs say, I want to protect the people around me. I want to help other drug users. I'm bringing sterile syringes to my friends. And we often sort of say, can we protect the community by doing X towards drug users? And to me, that's an almost incoherent statement, because drug users are members of the community and they are us. And I think in terms of the evidence base for MAT, I think the HEAL effort and other efforts are really essential. Let's take a metropolitan area and let's do a full court press and do naloxone and do everything that we know how to do as best as we can do it, do MAT as best as we can do it, bring implementation science to it to really evaluate how well it's being done, and see what are we getting and not getting from that. And I think we should all agree that it is essential that we create the data systems and really do the kind of aggressive research that we know how to do at the scale that we can do it. When Eric said $10 million, I'm all for taking $10 million in a grant. I'd be happy to take that, especially with our indirect rate. But we should be spending, $1 billion to say, what can we actually accomplish if we bring the A team and really do it, and then be fairly ruthless about what are we getting and not getting. And I do think that we have to be open to the idea that we're going to be disappointed by some of the things that we find. Anyway.
Okay, great. So thank you again to Jen and Harold.